Rachael Banks, Deborah Kafoury, Jennifer Vines, Chris Voss, and Kim Toevs.
Hi, can I ask a question? This is Ted Sickinger at the Oregonian. What I heard on the briefing was that it's too early to tell whether any of the surge in cases is due to the protests. I'm wondering, have you identified any cases that came out of the protests? And will you be sort of immediately making that kind of finding available if you do?
I can take that question if you guys would like. So far, we have identified very few, virtually no cases that are linked to the protest. It may be information that people don't choose to disclose to us. However, we do ask people in a very detailed way to account for all the different days and what their interactions have been with other individuals, starting a couple of days before they're infectious up through the date that we interview them. So we do a very in-depth interview with everyone, but it is voluntary. If we do start to identify a number of different cases associated with the protest, that would be information that we would share, just like any other significant trend we would see. Because we're still relying on the general guidance that we have set around what we release for the fact that this is a droplet transmission. If you go that phrase that we all used in February and March a long time ago, that we have not had a policy of disclosing, a specific date or time with a large grocery store that had a person in it that we had identified had COVID-19, for example. Same thing with the protest at this point, as far as we know. So we'll let you guys know about significant trends that we see, and we aren't seeing any right now, but that wouldn't name a specific place or site or location, unless it was a unique circumstance and we did feel like people had intimate and prolonged contact with other folks.
Can I follow up? So does that mean you have actually identified some cases? And I did hear Jennifer Vines last week during the briefing said, look, this is kind of and she didn't use exactly these words, but it was sort of worst case scenario of these, that we just don't want to see these large gatherings. And certainly this would be if you had some kind of super spreader. Why would you not make that information available to people and let people know, yeah, we're identifying cases out of the protests, and again, I heard you say today, if you feel like you need to go to the protests, go to the protests. Well, I mean, we're already in phase 3, really, aren't we? If this is what kind of the policy is.
There are a few different questions or comments mixed up in what you just said. We presume that there are a number of cases of people with COVID-19 that do not know they have it on any given day in any large setting, because there are a number of folks we have all come to know over the last few months who can be asymptomatic but be infectious. And currently our testing is primarily symptomatic people. And there are also people who can be in the early stages of infection. So I have no reason to believe that there are not people at the protests who have COVID infection right now, regardless of the case number that we have identified through the interviews with them, which is why all of our messaging has been that if people do feel compelled to protest, we do ask them to cover their faces and to keep distance from each other. I think we should make that assumption about any of the settings that we are all moving through. And even though we've been in the phase 0 of the executive order, there are certainly essential businesses that many folks have needed to visit that do have a large number of people in them. And that is why they all also try to follow the distancing and the face covering guidance.
And this is Jennifer Vines. I'll just speak to the way my comments have been portrayed. I think people mixing the way they have in the protests is a unique situation. I would say we are not in phase 3. I think what has happened recently in this country and the way that people have taken to the streets to confront racism and police brutality in particular, this is a unique time. We know in public health that racism affects people cradle to grave. It is most certainly a public health issue, and we're seeing it play out in COVID-19. So you're correct that we did put out advice for people who felt compelled to participate in the protests, and many did. And that included face coverings, again, being outside, using hand hygiene. We discouraged any use of chemical irritants that could make people cough. And so we will have to see what comes of this. And again, the public health interviews, we try to build trust so that people will share with us whether they've been to a protest or any other kind of mass gathering, so that we can better understand what are the risks as we potentially progress through different phases. What kind of interactions do pose the most risk? So as we learn those things, we will share them.
This is Kyle Boshi with KGW Channel 8. There seemed to be some discussion and debate about face coverings and whether there should be guidance or mandates surrounding the use of face coverings. I was hoping you folks could weigh in on that. And then also moving forward, what would that look like? What would that require as far as any kind of vote or approval from the commission?
I'll just start, sorry, this is Deborah Kafoury. I'll just start by saying that we today heard recommendations from our public health team, and I will let our public health folks discuss what those recommendations were.
I'll start. This is Jennifer Vines, Multnomah County Health Officer. I support and recommend face coverings, in particular indoors or outdoors, especially if you can't maintain 6 feet of distance. We've I think, been consistent with that message. So for those who want to see a face covering mandate, I think we share the same goal of seeing as many people as possible using face coverings routinely. That said, any kind of policy suggests an enforcement pathway. And again, we're in a time where, in particular, communities of color, Black, Indigenous, and others are essentially telling us that enforcement is immediately harmful to them. And we've seen that play out across the country and locally as well. So I think from a policy standpoint, I think there's further discussion that I heard at least one commissioner say she would like to have. From a public health standpoint, I think our recommendation is clear that we are asking people to wear face coverings routinely when they can't maintain 6 feet of distance, especially inside.
I'll ask another question, if you don't mind. As the last county to potentially enter phase 1, what lessons have you learned in observing other counties move forward?
I think what we've learned is that it's important to assess each county based on their own community. And one of the things that I'm most proud of at Multnomah County is that we have moved slowly and deliberately, and that we have engaged in all the members of our community. Communities have specific needs. We focused plans on the BIPOC community, on our elders, on people who live in congregate settings. We've developed individual plans to help those who are most vulnerable in our community. And so when we do move forward, which would be Friday if the state approves our plan, while we know we will see increased spread of this virus and we'll be continually assessing, we believe that we have a strong plan and a strong response.
So today, Kim Toevs put up a chart that showed that the number of Hispanics who have been tested in Multnomah County is 5.44%. Number of whites who've been tested is 51%. So everything the county says is equity, equity, equity when putting BIPOC people first. That's an enormous discrepancy that's completely out of whack with the results that you have presented. So please explain why there is a discrepancy, and please tell us how much responsibility for that discrepancy the county should bear.
The testing data that we showed is representative of the testing that is occurring through all hospital systems, all healthcare settings, public and private, as well as any county enterprises. So that's a large body of testing that's primarily driven from Providence, OHSU, Legacy, Kaiser, and then some of the community health clinics, some employer testing, as well as some small testing public health has provided for outbreaks. That probably speaks in part to differences in levels of accessibility of healthcare. And that, as we all know, includes health insurance status. It includes feeling safe, comfortable, or welcomed with culturally sensitive healthcare. It includes being able to take time off of work in order to seek healthcare. There's a whole variety of things there that do or do not allow someone to interact with healthcare. And then there's quite a bit of bias in the healthcare system about who gets tested and how those resources get used. So what you're seeing is reflective of responsibility that all of us have in healthcare and in public health together collectively to make the barriers to testing be much lower. Certainly there's been federal policy that has helped with some of the financial cost of COVID-19 testing, not allowing people's co-pays to be charged, for example. We have seen an increase in testing availability recently, and we are seeing an improvement in that. But what you point out, obviously, for sure, is the same concern that we've had, and it's been voiced by the community over and over again, that people run into barriers with having testing access. It's certainly more improved than it was previously, where the folks that were getting tested were only people who were hospitalized with severe pneumonia, for example. But there's still a lot to do to really make testing low barrier like it needs to be.
And I would add that precisely because of that gap in access is why we've included community testing as part of our reopening strategy, not just surely looking at the state's definition of are there the amount of tests in the system, perhaps at the, in the healthcare setting, but also standing up community test sites that are geographically based as well as culturally specific.
I would also add that just until recently, we had very little data on the race and ethnicity of those who had been tested and who had tested negative. And it was due to the work of the folks at Multnomah County for pushing to the state and pushing for those private providers that we're beginning to see those data come forward. We do know that we need more, and we need more partners to be asking the questions up front so that we can get the information and be able to have an accurate picture of who in our community has access to testing. That being said, as folks here have noted, we already know that there's a disparity in who's being tested, and that's why we're standing up our own community testing.
I think we have a question from Erin Ross. Erin, if you'd like to go ahead.
Yes, thank you. So given the data that you showed that shows that cases are increasing in communities of color, even though that might just be due to increased testing, but those cases are increasing even as they're decreasing in white communities. And given that we have these testing disparities, how can we currently reopen safely without disproportionately harming those communities, without having white communities go about like nothing is wrong and staying safe while Black people and people of color get infected by this disease?
Yeah, this is Jennifer Vines, Multnomah County Health Officer. I think that's a really difficult question. I think we looked hard at the absolute numbers of cases. So you see, it's clear to see a trend upward, but when you look, it's low double-digit numbers in a county of 800,000 people. I think Commissioner Myron captured it well when she said there may not be a perfect time to reopen. And so our hope and our plan is to have a good enough mitigation effort in place through contact tracing, through availability of testing, and then watching closely to see what happens with our numbers and adjusting accordingly. I think someone earlier today described this as a dance that we're doing with this virus, with our community, and it's going to come down to, again, everybody keeping 6 feet of distance, using a face covering, teleworking if they can, and we're going to be watching the numbers carefully and hopefully intervening so that we avoid the hospitalizations and deaths that we absolutely don't want to see from spread of this virus. And it's a really good question. I don't know if others have additional comments.
This is Kim. I would add that in addition to some of the economic considerations of not reopening, the level of closing down of services, of social connections, et cetera, has had other health impacts. So our holistic perspective is that unfortunately, the racial and ethnic disparities for COVID-19 are not absent for other health issues as well. As people have their daily exercise and healthy eating and active living, as people have that be interrupted, that can lead to some increased risks of chronic disease. You know, people weren't able to get any preventative dental care for a few months, right? We know that that has a huge impact long-term on folks. Educational access is a key to health later on in life. We did see immediately with the pandemic, due to the social isolation and the stresses and anxiety, we saw an increase in suicide rates, we saw an increase in domestic violence. So there's a whole lot of other considerations, and it's a matter of trade-offs and balance that we're looking at right now across a number of different issues that also impact inequitably different groups.
Elon, do you have a question?
Yeah, I'll jump in here. Elon Gluck. Can you hear me? Sorry about that. Okay. Yeah, thank you. Elon Glucklich from the Lund Report. You know, we're seeing national reporting in places like Arizona and Texas with suddenly kind of surging cases and some of those hospital beds, they are being stretched to the limit. Obviously, there was you guys presented that there is a lot of capacity, though there is perhaps some decrease in availability of ICU beds. I'm just wondering if to what extent maybe what's happening in some other urban areas like Phoenix, Arizona, maybe gives you guys caution going into the summer, you know, especially I believe given the governor's guidance that, you know, counties that went into phases likely wouldn't step back a phase. That may just apply for step 2 going back phase 2 to 1. But I mean, just to what extent are some of the national upticks that we're seeing maybe giving you concern or pause as you look to move forward in Multnomah?
I'll just say that we've had concern since the first outbreak that we saw in Washington State. And it has been our goal since to make sure that we slow the spread of this virus and make sure as many people as possible are healthy. So we are watching very carefully, not only what's happening around the country, but what's happening in our neighboring counties. We work very closely with Washington and Clackamas County to have a coordinated response. And we know that it doesn't stop here. Our focus and our attention on the data does not stop today. Doesn't stop just because if the state allows us to reopen to phase 1 on Friday, we will continue to watch the data as carefully as we have been, and we will continue to have briefings weekly with our board to update them on what we're learning. I would also just add that I know we've said this a couple of times, but I think it's important to realize that until we have a vaccine or a cure, we're going to be living with this virus. And it's going to be, we're going to be constantly rebalancing, checking to see on our assumptions whether our plans are working, changing our direction, our focus, as we have been since the first time that we've had a case in Multnomah County.
Any other questions? Anything else anyone would like to ask our panelists?
Yeah, this is Ted Sickinger again. I was looking yesterday at your dashboard on kind of the racial disparities in terms of cases, deaths, and hospitalizations. And from the data on there, it was just really comparing the percentage of the population to the incidence of those. And it looked like this was primarily an issue centered in the Hispanic community. But I did hear you say today that when you remove the, I guess the white people that have been diagnosed or died or hospitalized, you know, the congregate care examples, is that situation actually looks worse than that dashboard data might reflect?
Well, not everyone who lives in the long-term care facilities is white, first of all. Second of all, you know, I heard you say it's primarily an issue in the Hispanic community. At the end of the day, it's pretty obvious to me it's still a significant issue in all of our communities, white folks too. It's certainly not only issue among the Latinx population. We have had increases in Pacific Islander population that show significant disparities. We see clusters across a number of different communities, including African American, African immigrant. So that's why our goal is to be culturally specific where we need to be, to sort of meet people where they're at with staff who are actually from their communities. And every situation is going to need a slightly different approach to how to solve it. A number of our cases more recently have been among seasonal migrant farm workers, for example. So as we go through different outbreaks, different phases, different neighborhoods, and it will move around, we'll see increases and decreases in different areas. So we definitely, I don't think there's a single group that is immune from some clusters or some outbreaks or some increases.
I'm going to do a last call here since we're coming up on the hour. Does anybody have any last final questions for our panelists? We definitely appreciate all of our panelists for joining us. We appreciate you being here. We will take this recording, which is complete, even if the Facebook Live keeps dropping, and we'll have it on YouTube later in case you missed something. But thanks everyone for joining us. Have a good afternoon and be well.